I'm Dr. Stuart Menakar from the Palo Alto Medical Foundation Los Gatos Clinic. Welcome to Health Connections on KCAT Television, Los Gatos, Montesreno. On tonight's program, I'm with my colleague, Dr. Ali Shizadi. He's from our Department of Neurosurgery. Welcome, Ali. Nice to see you.
Good to see you. Thanks for having me.
On tonight's program, we're going to talk about neurosurgery in general, but mostly about back pain. That's something that our neurosurgeons help us out with on our most difficult patients. So, Ali, first let's start. If you would please tell us a little bit about yourself and why did you decide to be a neurosurgeon?
I grew up in Houston and went to University of Houston for my undergrad. I was very interested in neurosciences during my undergrad years. Did research in neurosciences at University of Texas at Houston. I did 2 years of research in stroke. Growing up in a family of doctors, I was very interested in medicine, and doing the research really fascinated me to the field of medicine. So I applied to medical school and completed my training in medicine at Texas Tech School of Medicine. During my early years, I worked with a neurosurgeon at Texas Tech School of Medicine and was very much sold on the field of neurosurgery. After completing my clinical years, I applied to neurosurgery and did my training at Cedars-Sinai Neurosurgery Department in Los Angeles. After completing my residency, I did a year of fellowship in spine, complex spine and spine surgery at Cedars-Sinai, and been in Los Gatos for the past 4 years.
And we're happy to have Dr. Shizadi as part of our Palo Alto Medical Foundation team of doctors here in Los Gatos. So we're thrilled about that. Mm-hmm. You mentioned neurosurgery,
yes,
and that you had some fellowship training in spine and complex spine surgery. Yes. I'm going to speak for our viewers. Sure. Most of the time, I think when people imagine neurosurgeons and what they do, they think about some guy with a brain in front of him and cameras and really long skinny instruments and taking care of all kinds of crazy things inside the head, as if you could just open it up and take care of it. There's no candy inside for us today. Another day. So tell us, what do neurosurgeons do? Is that really an accurate picture of what a neurosurgeon does?
To some extent, neurosurgery is a field that involves taking care of obviously surgical aspect of brain, but also the big part of neurosurgery is taking care of spine issues. So basically, neurosurgery takes care of all the aspects of nervous system, which includes brain, spine, and the peripheral nerves. As you can imagine, back pain and neck pain are very common in our society, and thank God we don't have a lot of patients with brain tumors and aneurysms. But talking about neurosurgery, that basically covers everything that involves the pathology of those systems.
Hopefully, most of us will never need a neurosurgeon for our back troubles.
That's a good thing.
Yeah, that is a good thing. But let's back up a little bit, Ali, if that's okay.
Sure.
And if you would please tell me a little bit about, why is back pain such a problem? Why is it enough of an issue that we would have a whole show, or most of a show about back pain? And then, how can our patients prevent back pain? We've talked on our programs an awful lot about prevention as being an important thing for all of our doctors here at the Palo Alto Medical Foundation.
Sure.
And how can our patients stay away from you?
So, back pain is actually the second most common reason to go see your primary doctor or to see a doctor. Number one being the common cold. So you can imagine that almost all of us are going to have back pain throughout our lifetime. And one of the reasons is spine is basically the backbone of our bodies. And my old boss used to call it the backbone of the industry. And there's some truth in that. It's really what holds you up and around and makes you walk and be straight. So having said that, it's going to, throughout our lifetime, we're going to work on our spine, we're going to do different activities that's going to hurt our back, hurt our muscles, and put strain on our back. So going through life, we're going to have wear and tear, and just part of life, and we're going to have accidents or traumas that makes us more prone to having back pain.
Obviously, we can work too hard, and that can lead to wear and tear, and age and time will lead to wear and tear. But if I'm a young person saying, gee, I have a really physical job, and I love my job, I want to be able to do it for 50 years, what should I be doing to help prevent future back troubles?
Sure. One thing that's really important in regard to back pain is prevention that you mentioned earlier. And the prevention starts in early years, starting actually in our teenagers, and that includes building core strength, building up on our core muscles and building strength on those. Everyone hears that don't pick up things straight, don't pick it up with your back, use your knees, and there's a lot of truth in that. Those things got to start early on. You can't start them when your back is already affected, you hurt your back. You got to start it in your early years, build up those muscles, and prevent loading on your back as much as possible.
So the best way to protect your back is to have a six-pack, right?
There's some truth in
I
that, yes.
think I missed out on that one, but how about flexibility? Should we be working on stretching for our back to keep it strong?
We should, and that comes with, I think, building up the core strength is not just building up the muscles in our abdomen or our back, it's also building more flexible and doing the routine exercises. You know, I'll always send my surgical patients to physical therapy after surgery, but when I have big surgery that involves months of recovery, I have them start on physical therapy before surgery, months before that. And that part of it goes to what you're alluding to, is building the strength and being more flexible, being involved using those muscles. Because the stronger those muscles are, the more flexible your back is and your joints are, the better your back or your spine is going to be.
I agree completely. As a primary care doctor, of course, we're on the same page there. I tell all of my patients that whatever joint you may have in your body that potentially is not working as well as it could, or if you want to protect joints in your body, the very best thing you can do is make sure the muscles that move that joint and support the joint are strong, and that you keep the joint flexible. Also, one thing that most people don't think about, but I think, Ali, you would probably agree, a great way to help protect your back is not to smoke. What does smoking do to your back?
You know, everyone thinks about smoking as lung cancer, but in our field, smoking not only affects your lungs and affects your anesthesia problems, that it gives you problems with anesthesia. It affects the blood supply to your spine. And as the blood supply gets affected to your vertebrae and disc, then your degeneration is going to be faster. You're going to have a rapid decline in your spine. So it accelerates the degeneration of the disc disease, accelerates the pathology of the spine, and causes a lot of problems in regard to back pain.
Well, I'm sorry if I sound like a broken record for all of you viewers who watch many of our programs, but please don't smoke. It's not good for any part of your health, including your back. Also, we know that regardless of how careful we are, some people over time will develop arthritis.
Yes.
And I know that for most of my patients, if we're doing an x-ray for something else, we may see a little bit of arthritis, even if they're not having pain. We see some arthritis in the spine commonly as young as maybe 40 years or something. What can we do to help prevent arthritis or to make sure that it doesn't lead to a lot of back pain?
Sure. You know, arthritis is a very common problem, and it's the same process in your joints, like you mentioned. It goes into your spine. In regard to preventing arthritis, you know, there's a genetic component to it. If you have a family history that has a lot of arthritis, then you're more prone to getting that. So for those patients especially, it's very important to be more active and doing the healthy exercises, and not just do one exercise, but use all their joints and be flexible and keep the muscles healthy, keep the joints healthy.
It sounds like you're telling us that a little bit of cross-training is good and healthy for your back too, as it is for many joints. If we do the same exercise, the same stretches, the same weightlifting or resistance training all the time, we may get some muscle imbalance or troubles, and that can affect your back as well.
For sure.
So cross-training is important too. Let's say I wake up today and my back hurts, and I think that I've been good about taking care of myself, trying to prevent troubles. What should I do? If I feel I need help, what's the first thing I should do?
Unfortunately, what you're describing is something that will happen to most of us throughout a lifetime. The first thing that I recommend to my patients is if you start having back pain, try rest, but not completely laying down. Just try rest with some minimal activities, and take anti-inflammatories. Over-the-counter anti-inflammatories are safe, and as long as you're drinking and you're not upsetting your stomach, it can be taken safely. If the pain continues for 2 or 3 days and it's not getting better, then you should start by seeing your primary doctor and start by getting examined and making sure that it's nothing more serious than just a routine back pain. And usually from there, physical therapy is started. X-rays are taken to make sure there's no bony abnormality, no fractures, and no malalignment of the spine. The routine process is once the patient goes through the course of physical therapy, which usually lasts 4 to 6 weeks, and they're not better, then they talk to their doctors and they go to the next step, which usually is seeing a physiatrist or getting an MRI to be evaluated by a surgeon or a spine specialist.
Well, so Ali, does everybody who comes in to see their primary care doctor need x-rays of the back?
No, they don't, because a lot of times it's just a muscle spasm that will get better by anti-inflammatories, rest, or physical therapy. But if the pain continues, then you start taking next step, which includes X-rays or CTs or MRIs, depending on what the symptoms are.
And by anti-inflammatories, Dr. Shizadi means anti-inflammatory drugs like ibuprofen or naproxen, as would be found in Advil or Aleve, something like that. And we would call this a conservative approach to management of back pain, because most people with back pain never need X-rays, MRIs, CT scans, or a surgeon's knife. Once in a while, Ali, when a patient comes to me, appropriately, as you said, to see their primary care doctor, they have signs that you and I would call warning signs of a need for something extra to be done right away. Could you tell our viewers a little bit about what kinds of things are dangerous that need to be worried about?
Basically, in the first step, and the first sign of it is basically losing strength in your arms or legs. If you're losing strength and, for example, you're able to walk and you're not able to walk, or if you're able to walk normal, but now you're dragging your foot. If you're able to pick up a gallon of milk, but now that becomes difficult for you. Those are very alarming signs and needs immediate response of studies and maybe being seen by a spine specialist urgently. The other one is losing control of your bowels and bladder. If you're not able to control them, then usually it starts as overflow incontinence, which means, like, think about a glass of water that you can fill it with so much water, and after a while the water starts filling out. And that's normal pattern. They can't control the bladder, and when we see them, the bladder is basically full. Those are the most alarming sign of spine pathology. The other ones are basically if they have waited maybe like a month or two, and now the pain has gotten to a point that they can't walk and it's shooting down their legs in a specific pattern that corresponds to a specific nerve. That's not improved with the conservative measures that we just talked about. Those are alarming signs. That can be something more serious, maybe a big disc herniation. That is, the nerve is getting pinched and it's not improving. That's another one that we should be thinking about. In regard to spine, you always have to think about the thoracic and cervical spine, which they're more high real estate value part of the spine, and there basically you think about pathologies of the spinal cord rather than the nerves itself. And for those, any abnormality of losing control of the dexterity or having difficulty typing, texting, or balance problems, those can be very concerning, because that's basically saying something is pressing on the spinal cord itself.
Okay, so we've talked about worrisome signs of back troubles that might require more investigation, things such as loss of control of bowels or bladder, weakness in the legs, or a weakness and difficulty doing things with the hands and the arms. Those are all things that primary care doctors know to watch for. So what happens if I see somebody and I'm concerned that maybe they have weakness in their legs? What should our patients expect if they see their primary care doctor and find that sort of thing?
I think if it gets to that point, hopefully no one gets to that point, but if they get to that point that they have weakness, then the next step is to obtaining an MRI of that aspect of the spine. If it's the legs, obviously the lumbar spine, arms, you're looking at the neck. And once we get the MRI, then we start looking to see if there's any soft tissue or maybe disc herniation, maybe blood clot, or anything that could be pressing down on the nerves or the spinal cord itself, and take it from there on.
So all kinds of things that could put pressure on the spinal cord or on the nerves can lead to weakness or some of these other things we've talked about.
Exactly.
Of course, I think the one we worry about most is if something's pushing on the spinal cord, and that's considered a medical emergency.
It is.
And that's when they get to see you.
Exactly.
So if I have a patient and I get their MRI report from the radiology specialist who says there is something pushing on the spinal cord, I'll probably send them to the emergency room. What do you say to them, or what happens next when you come to see them?
So first thing is, you come in and examine the patient to see how weak they are and how long has that weakness been going on. If the weakness has started acutely, meaning that I see them in the afternoon and that day they just started having weakness, and there's a big disc pressing down on their spinal cord or pressing down on their nerve, then you talk about emergent surgery. I'll usually tell my patients it's like looking at, having your thumb on your eye. That really bothers you. And until you take that pressure off your eye, you're not feeling comfortable. So it's the same pathology or same philosophy with your spine. If something is pressing on your nerves or on your spine, you want to take that pressure off as fast as you can. And that's where the faster you take that pressure off, or the sooner you take that pressure off, the better your recovery is going to be. Unfortunately, even if someone has weakness that's been going on for months and they've been dragging their foot, they have a foot drop, surgeries may not give them the best, may not improve them immediately, but it will give them the best chance of improvement. So even for those patients, it's important to take that pressure off their spinal cord.
Are there any non-surgical treatments, medicines or something like that that might help someone?
Definitely. If there's, we talked about the extreme form, which is basically weakness or, pressure on the spinal cord itself. But if there's just a mild pressure and it's not causing any weakness and it's just causing some irritation of the nerves, that's when we talk about maybe having epidural steroid injections. People think about epidurals as during delivery, everyone hears, I'm having an epidural, but that's a different kind of epidural. The epidural is just a space, and we talk about epidural steroid injections. They just inject some steroids and numbing medications. And that really helps us in the sense of diagnostic and therapeutic purposes. Diagnostic in a sense that if I feel like that's, for example, L5 nerve that's been irritated, one of the nerves in the lower back, then I can have the pain doctors inject the medication. If the pain gets better, then I confirm my diagnosis. And if it gets better and continues to improve, then that's a therapeutic aspect of it. A lot of my patients have that and they don't need any surgery and they recover completely. That usually works really nicely for patients who have very small disc herniation or more of an inflammation rather than a big disc pressing on their nerves, and really prevents them from undergoing surgery.
Well, just for our viewers, to make sure everyone understands, the dura is a layer of tissue that surrounds the spinal cord and the nerves, and the epidural space is the place we would insert a needle to inject a little bit of steroid medication to reduce inflammation, and as you mentioned, a little bit of pain medicine to tell us if we've got the medicine in the right spot.
Exactly.
As you said, many of my patients see the physiatrist who does the epidural steroid injection, and they get good relief for weeks or months or years, but not everybody does.
Yes.
We do occasionally have folks who have terrible, unrelenting pain. What do you do next?
So at that point, that's when we say they've failed all non-surgical management. Now, I tell my patients basically there are three things that would say you need to have surgery. One is what we just talked about, that you failed all non-surgical management, epidurals, anti-inflammatories, physical therapy. The other one is if you have weakness that we talked about, or the third one is spinal cord problem. So we've talked about all three of them. At this point, if they have obvious pathology on their MRIs and or their studies, then we talk about surgery. Now, surgery can involve, depending on the pathology, can involve either just decompressing the nerve and taking the pressure off the nerve or the spinal cord, or stabilizing the spine. And usually with the stabilization, that involves taking the pressure off and stabilizing. You only stabilize the spine if you see anatomical abnormality, meaning that think about a tower that the tower at the bottom of the tower is loose, and every time the wind comes, this whole tower is shaking abnormally. That's when you have to basically reinforce it. Think about your house, you have to reinforce the foundation. That's really the idea of when you need a fusion. And basically, sometimes we iatrogenically, by doing the surgery, we destabilize the spine. That means if you have to take too much bone off to take the pressure off the nerves, then we know that the spine is going to become unstable. So that's when we do a fusion and stabilize it. And fusion, there are different forms to the fusion, different instruments that we have to put in, but the bottom line is you're connecting one segment of the spine to another segment to make sure that there's reinforcement in the structure of the spine.
So tell us, Ali, if you would, what is spinal stenosis and what do you do about that?
Sure. Spinal stenosis is basically narrowing of the canal. There's a canal that the nerves are running through, and once that canal gets narrowed, the fancy name for it is we get stenosis. And think about you're sitting in a room and the roof is basically really close to the floor and you feel really tight, and that's really the feeling that the nerves are having. So most of these patients, they get what's called neurogenic claudication, which is when they start walking, they get back pain, and as a result of that, they get tightness in their legs, and that's basically, it's so tight in the canal that the nerves are not getting enough blood supply. So as a result, the nerves are getting tired. Just like if you start running, and after running a marathon or 1 or 2 miles, you start getting cramps in your legs. The nerves feel the same way. To help those kind of symptoms, you basically have to, like in a room, you have to lift up the roof of the room and create more space. That involves taking the lamina off or doing a small surgery that's called laminectomy, which means taking the aspect of a bone off to create more space for the nerves.
You mentioned reduced space. I know there's another thing that happens in the spine where we say the foramina, the neural foramina are narrowing from arthritis or something.
Yeah.
Explain that for us, if you would, please.
That one is basically, foramina is basically the hole that the nerve is coming out of. If that hole gets narrowed either by a disc protruding into the foramen or as a result of arthritis building up or ligament getting thick, then you have to open up the foramen. That's more of a roto-rooter surgery. You basically go in and open up the hole that the nerve is coming out, and basically the nerve feels better.
Well, so on another show, we had one of our cardiologists talk about how he's a plumber. Now we know that neurosurgeons are plumbers too. A little roto-rooter action. I want to mention something too, that with spinal stenosis, when you have narrowing around the spinal cord, it can affect the entire rest of the spinal cord below that level. Whereas the foramina are on the sides, and if those get narrow, it really affects just the nerve, one nerve that comes off the spinal cord through the hole to the side.
Yes,
That's
accurate? Correct. That's perfect.
I think we've talked a lot about different causes of back pain, things we can do to prevent them, different kinds of evaluations, treatments, even surgical treatments. But tell us, if you would, a little bit about other kinds of back surgery you do, besides those that are just related to spinal stenosis, foraminal narrowing, discs, and those kinds of things. I know that you take care of other problems like scoliosis or other things.
One of the things that I do and my colleagues do a lot in the spine surgery is trauma and deformity. There are so many different ways to do trauma surgery and deformity surgery nowadays. Obviously, if you fracture your back and you have a unstable spine or bone protruding into the canal, you need to take the pressure off and stabilize that. We can do that nowadays with minimally invasive spine surgery, which basically involves not opening the back and just pushing the screws through the muscle and have a very fast recovery. Almost infection rate is 0 and very minimal blood loss. And patients can be up and around walking the next day and not even get discharged within 48 hours from the hospital. The other one is deformity, which is scoliosis. Unfortunately, as we go through life, that curvature in our spine is going to get less and less. It's just a part of the aging process of the spine. So we've learned in the past 10 years that we have to restore that curvature, and a lot of our older patients are having deformity and or kyphosis by leaning forward and not being able to stand straight. So that's where we basically can combine what we knew in the old days of open spine surgery with the minimal invasive approaches and combine the two together and kind of do a maximal access surgery, meaning we don't have to open up as much, but we do enough to give the best outcome to our patients.
So Ali, what's up and coming? What's new and exciting in developments for back and other neurosurgical care?
Sure. The one thing that has been in the market for spine surgery in the US for the past decade, and it's been growing really fast, is artificial disc. We were able to do the artificial disc surgery for cervical and lumbar spine. However, lumbar spine success rate has not been as good as the cervical. But nowadays, for someone in like 30s, 40s, someone in their 50s who don't have osteoporosis, who have healthy bone, and they only have one level disease in their neck, and now we're able to go ahead and do the same surgery as we were able to do in the past, same steps of the surgery, but instead of fusing their neck, we can place this device that restores the full range of motion in their neck. And patients really like it. We have a lot of data now that supports this surgery, and it basically allows us to reset the clock. And by doing artificial disc, we're able to prevent degeneration of the levels above and below, whereas with fusion, sometimes you can accelerate the degeneration of those levels. So that's been really exciting, and the insurance companies are approving those surgeries better because the data is very strong about those things. I think the field of spine is expanding in the sense of minimally invasive spine surgery. That thing has been really exciting for the past 10 years or so. And, at first it was a lot of back and forth, what's right, what's not right, what's really needs to be done minimally and what not. But now we found the surgery that work really nicely, and we're expanding on those really almost every day or every month new technique is coming out. But the main topic in the spine surgery that's been really changed everything the past 10 or 15 years has been lordosis of the lumbar spine. We know that every time we do a surgery on someone's back, we have to look at the curvature of their lower back and compare that to their pelvic parameters. Before, we used to only look at the lumbar spine and say, that's all you need to do. But now we're looking at the whole spine from neck down. So when you do a fusion or when you do a deformity surgery, you have to look at the whole spine and not just look at one segment of it.
You're telling me that with advances in neurosurgery, you're focusing more on function and movement, not just on how do we maintain stability and reduce pain. And as part of that, the normal curvatures, so in the neck or cervical spine, we curve one way. In the chest, we curve back the other way. That's the thoracic spine. And in the low back, we curve back the other way. That's the lumbar spine. And we haven't talked about the sacrum, but that's the low part underneath our buttocks. So our spine has its own natural curves, very much like a spring.
Yes.
And that's part of how our amazing mechanism of a body absorbs energy without all of us having troubles.
Yes.
How about vertebroplasty? So what's going on with rebuilding bones that have been fractured or have osteoporosis or something about it?
It's a very nice thing to be able to do for our patients, especially our older patients who have osteoporosis. In years ago, patients would fall down, break their back, and be bedridden for months, and then they get all these other problems of pneumonia and complications from that. But nowadays, we're able to do what's called vertebroplasty or kyphoplasty, which is kind of the same idea that you put a needle in the back and you're able to inject cement. This is a different kind of cement, not the one you buy at Home Depot. You inject the cement in, and basically it takes 10 minutes or so, and the patient is able to leave the hospital same day and be pain-free. So I always tell my patients it's 10-minute procedure, and they have a great success with that. It's worth a try, and if you pick the right patients, patients are going to be very happy and satisfied.
Well, I'd like to take a moment and talk about one last topic, I think, before we wrap up. And that is, I know that for some of our most difficult cases to treat, people who don't respond well to surgical, maybe fusion of the spine or vertebroplasty or those kinds of things, or where there's already damage to nerves. And then maybe sometimes people with chronic pain, we deal with this in the brain. But tell us a little bit, if you would, about nerve stimulators and other things like that we use for chronic pain control.
Basically, it's think about you're having a headache or your leg is hurting, and I start tickling your other arm, and you start forgetting about your pain. That's the same idea of the spinal cord stimulator. It basically sends signals throughout your spine and makes your body have a less of a response to the pain that's coming down, or pain that's the source of your pain. And it's a nice surgery in the sense that you have a trial before the placement of the generator into your body. So these patients who have failed all the conservative measures or surgeries or have this chronic pain, they undergo a trial of spinal cord stimulator, which is usually done by the pain doctors. They place the electrodes, they have them for a couple of days, and if they get over 70% of improvement in their pain, then they become a candidate for surgery. And the surgery is like an hour surgery, 30 minutes to an hour surgery, one night in the hospital. And they're already going into the surgery, they already know that they're going to have a good response because they've had the trial. And for some of our older patients who have really bad pain, or the patient who we just talked about that failed all the conservative measures, this can be a very good alternative.
So you implant the whole thing inside the person once we know the one that was on the outside worked well.
Exactly.
What happens when it runs out of batteries?
The batteries usually last between 5 to 7 years, and if once it runs out, you basically just go ahead and make an incision on top of that and change the battery. So the implant is basically, the battery is separate, and is a separate incision than the spine. You put the generator on the spine and you tunnel it to a different location for the battery. So changing the battery is like very simple procedure, outpatient process, and is very well tolerated.
I think we've talked about an awful lot with regards to neurosurgery and back care, both non-surgical and surgical, as well as how we manage folks with chronic back pain. So I want to thank you for joining me on the program today.
Me.
It's great to have you here at Palo Alto Medical Foundation in Los Gatos. And for all of us here from the Palo Alto Medical Foundation in Los Gatos, I just want to say thank you for joining us on Health Connections tonight, KCAT Television, Los Gatos, Monte Sereno. It's always our greatest hope that we can help take care of all of your medical needs, including management of simple and complex back pain and even more worrisome chronic back pain with our wonderful team of doctors, primary care doctors, specialists, and surgeons. Thank you very much for joining us.